My name is Erin. I lead the benefits practice at Seubert Associates. We all know that COVID-19 has impacted our personal lives and businesses in unique ways, but we share certain commonalities with how it impacts health and welfare plans, compliance, and purchasing. Leading off today's presentation is Erin Powell, who is Seubert's Employee Benefits Compliance Officer. So she's going to go through each of the changes in legislation and benefit plans as it relates to the compliance component of administering the COVID impact on these plans. Following Erin, John Frissora, a key business partner of Seubert Associates, is going to go through true unbiased statistics related to COVID-19 and give a high-level outlook on what we can expect moving forward in regards to healthcare purchasing and financing. So in summary, we will keep today's discussion in regards to compliance and math as light and energetic as possible. And the format will include Erin, followed by John, followed by a Q&A session. So again, thank you very much for your time today. I apologize for the mix-up in the beginning, and I will turn it over to Erin at this point. Thank you, everyone.
Great. Thanks, Eric. We'll give this one another try here. So 2 new laws we've all been hearing a lot about in the past few months. First up, we have the Families First, commonly referred to, and then the CARES Act. And both of these laws have had impact on employee benefit plan designs. Families First, most impactful for creating a paid leave for employees impacted by coronavirus. And while on leave, it requires group health plan coverage to continue for both the employee and the dependents. Finally, under Families First, there is COVID-19 testing required to be covered without cost sharing. The CARES Act, passed later in March, impacts employee group health plans by expanding what must be covered under that COVID-19 testing. It requires coverage for vaccines when the vaccines become available, and there is also a minimal impact to telehealth, as well as items available for reimbursement under a health savings account, a health reimbursement arrangement, or a health flexible spending account. In addition to Families First and CARES, there has been a bevy of new regulatory guidance issued. They're listed here for your reference. We'll go into, again, what the guidance means for group health plans. In addition to formal guidance, the agencies, and that means the IRS, Department of Labor, and Health and Human Services, often issue frequently asked questions where they clarify what they meant in the formal guidance. So anytime that you're looking for the most recent information, it's always important to check the FAQs, because the government has changed their mind several times on what they mean under coronavirus information. Benefit changes. COVID-19 testing, that requires that group health plans must cover COVID-19 testing without cost sharing. Cost sharing means no deductible copays or coinsurance. And additionally, in subsequent frequently asked questions issued by the federal government, that also expands coverage for antibody testing without cost sharing. And then the CARES Act, what that did is that expanded what must be covered without cost sharing related to services when you get a COVID-19 test. So if you went to the doctor, you went to urgent care, and you may have had a copay associated with getting that test, that copay now has to be eliminated. New rules for high deductible health plans. High deductible health plan, if you're not familiar with that, that is a type of plan design with parameters set by the IRS on deductibles and out-of-pocket maximums. Generally, a high deductible health plan is paired with a health savings account where employees can make pre-tax contributions. So how these types of plans are operated are due to IRS regulation, and they have to generally comply with what the IRS said. Due to coronavirus, the IRS relaxed some of these rules and they said that high deductible health plans can pay for testing for COVID-19 as required under Families First and CARES, but also can pay for treatment for coronavirus before a deductible has to be satisfied. The coverage for treatment is at the discretion of the insurer, or if you are self-insured, at the discretion of the employer or the TPA that you're using to administer your claims. Additionally, the CARES Act allows high deductible health plans to cover telehealth services without a deductible. And briefly to touch on telehealth, you may have heard a lot of information in the news lately regarding telehealth. The Trump administration issued an executive order where the president is stating he is mandating telehealth services. That mandate only applies to Medicare and Medicaid plans. That mandate does not extend to the group health plan market. COVID-19 vaccines, under the Affordable Care Act, otherwise known as Obamacare, preventative services have to be covered without cost sharing. One of those preventative services is considered vaccines. And generally, when the federal government dictates that a new item be listed to the preventative services schedule, a group health plan has a year to comply with that mandate. What CARES did is it said you got to cover the vaccine almost immediately. The CARES Act is giving group health plans 15 days to comply with coverage for vaccines once a vaccine is recommended by the FDA. So I'm sure our insurer partners and our third-party administrators are going to jump right to as soon as we get a recommended vaccine. Next up is new eligible expenses for health savings accounts, health reimbursement arrangements, and health FSAs. Two items here that the CARES Act impacted. Under the Affordable Care Act, generally to get an over-the-counter medication reimbursed through one of these programs, you had to have a prescription. CARES Act removed that prescription requirement to have over-the-counter items or medicines, reimbursed. And they also stated that menstrual care products can now be added to the eligible list. These expenses or these items are at the discretion of the employer. So if you would like to update your health reimbursement arrangement or your health FSA to allow these items, you can contact your Seubert representative and we'll work with your third-party administrator to make sure that your plan is amended appropriately. If your employees have a health savings account, there's nothing you need to do to allow these items. The IRS has made the changes on their end. Some additional health FSA changes to think about. Again, these two items that I'm talking about here, the extended claims period, as well as the increased carryover amount, are discretionary for employers. So you can choose to do this or you can choose not to. However, the IRS has said that employees may have additional time to submit FSA claims following the end of the plan year. They are allowing an additional carryover amount. The IRS is giving employees a whole $50 more to carry over. So that is good. Big spenders, the IRS. Eligibility and enrollment. Mid-year plan changes. So generally when employees make a pre-tax contribution and elect coverage for one of their benefits, that election is locked in for a full 12-month period, unless the employee has a qualifying event. And the IRS created coronavirus as a new qualifying event. And this qualifying event is discretionary for employers, so you can choose to allow this, but generally an employee can make a plan change due to coronavirus. You need to amend your Section 125 plan, and the IRS is giving you an extremely long time to do this. You have till the end of 2021 to amend your plan. So what can employees do if you do allow this change? You can allow employees to elect coverage if they previously declined, switch between plans, or revoke an election if they no longer can pay for coverage. And a health plan is defined as your medical, your dental, your vision plan. So They have a lot of flexibility there. They can also make changes to their health flexible spending account or their dependent care assistance program. This one we've seen very popular with employers. Under this, they can make a new election and they can decrease or increase an existing election. And with daycares and after-school programs being closed, we're seeing a lot of employees choose to decrease or eliminate their dependent care assistance program. Again, like I mentioned, this is up to the employer. You can allow employees to make changes only to their health FSA or DCAP, or you can allow them to make changes to anything generally that is pre-tax. So again, up to you. And if you do want to do that, let us know, and we will make sure your plan is amended appropriately. Extended plan deadlines. I think this has been the most difficult area for our employer groups. The Department of Labor and the IRS issued a joint rule that allows employees more time to take certain actions, most significantly the Cobra coverage. But this applies also to HIPAA special enrollment rights and things they can do with filing claims. And the timeframes for Cobra, HIPAA, and claims must be disregarded during the outbreak period. And the outbreak period is defined as beginning on March 1st and currently does not have a deadline. However, to provide you with a little bit of insight on what the government is thinking about ending the outbreak period, on July 23rd, the Secretary of Health and Human Services extended the public health emergency for 90 days. So that would put us at I believe October 22nd will be the next time that the outbreak period is looked at. Again, the normal deadlines will resume after the federal government determines the end of the outbreak period. So Cobra deadlines, the following deadlines are extended during the outbreak period. So employees will have additional time after the end of the outbreak period to make an initial Cobra election, to make their initial Cobra premium payment, or to pay subsequent premiums. Additionally, they'll have more time to let you as the employer know if they've been accepted under Social Security for disability. And the joint rule also allows employers more time to get your Cobra election notices out. If you can get your notices out on time, I generally recommend that you continue to do so, but you do have wiggle room. So if you miss it by a day or two, do not get yourself worried. Finally, other deadlines during the outbreak period are the HIPAA special enrollment. Now, HIPAA has some qualifying events that mirror much like the IRS qualifying events, but are defined a little bit differently. And they have a little bit more window of time. So employees may come to you after the outbreak period with a qualifying event under HIPAA, and those can be qualifying for Medicaid, qualifying for Medicare, an employee or an employee's child being eligible for CHIP, or if an employee has a new baby or gains another dependent. Generally, those are special events under HIPAA. Again, getting more time to let you know as the plan administrator they need to make a change. The last three items here will probably be handled by your insurer or your third-party administrator if you are self-insured. Employees get more time to file a claim under the plan, to file an appeal on a claim that was declined, or file an external review for an adverse benefit determination. Generally, when a claim is not paid to their liking, they get an appeal and then they get an external review. So again, more time frames to do those things. And with that, that concludes the compliance aspect of how COVID-19 is impacting employee benefit programs. And I'd love to turn the presentation over to John.
Great. Thank you very much, Erin, and thanks to all of you for attending today, and special thanks for Seubert for hosting this seminar. My name is John Frissora. I'm president of Seubert Associates. My firm specializes in healthcare financing and analytics. I've been in the industry for 35 years. I've held senior positions at the two major health systems located in town. So around the beginning of March, a lot of conversation around COVID. Just based on my background, I was getting questions from friends, families, customers. Had a lot of dialogue with a lot of the physicians that I've got to know during my career around what was COVID and what was to be expected, what was going on. A lot of data out there, or a lot of messaging coming from the media. So what I set out to do was finding a reliable data source, and landed on information that was readily available each day from the CDC and Johns Hopkins. So since March 16th, I've spent the first hour and a half of every morning, without missing a day, downloading the data. About the second week in April, we published our first article email blast and tried to avoid the political issues that have cropped up because of COVID. And then we published every other week, getting feedback and questions from our previous article and addressing those in subsequent. So I wanted to share just a little bit of this information with you today. This is our CDC Scoreboard, and this is data, again, that we have been gathering each day since March 16th. Right before Memorial Day, COVID was really starting to slow down. Number of cases, fatalities, and I truthfully thought I was going to be out of this COVID data business and was getting ready to move on to the regular work that we perform. Then we hit something that they're indicating as the surge. The good news is the data that's out there is extremely easy to follow, and it's actually very good. It actually lets you bring in new cases each day. Those cases are classified as being recovered or just non-symptomatic. And then you have fatalities or deaths for the day. And then it also leaves you what individuals are currently receiving critical care. So since the beginning of COVID through May 21st, which is the Thursday right before Memorial Day, you'll see there was 1,593 new COVID cases. Out of those 1,593, 1,478 of those cases had recovered or had no symptoms to begin with. So they were, classified as recovered. There were 96,805 deaths classified as COVID deaths. And that, if you did the math real quick, that would relieve you with 17,815 people that were in critical care at that time. This is throughout the country. The recovery rate was just about 94%. Death rate, death rate was 6.1%. And the total tests that were administered at that time in the country were just a little bit north of 14 million. So the infectious rate for the tested population was over 11%. Infectious rate is simply just taking your total COVID cases, the 1,593, and dividing it by the number of tests, the 14 million. That is your infectious rate. At that time, we had tested 4% of the population. So 14 million tests represents about 4% of the US population. If you move over to the next column, so this is what's happened since May 21st until August 28th, the day that I had to turn my slides over to Seubert. We start with those same cases that were in critical care. There were 17,800 of those. New cases since May 21st were 4.4 million. Total recoveries, very similar, 4.3 million. And total deaths had come in at 88,000, and cases in critical care had dropped to 16,000 cases. The recovery rate had spiked tremendously up to 98%. Death rate had declined down to 2%. Total tests surged up to 65 million tests just administered between May 21st and August 28th. Infectious rate, again, 6.8%. So this data is, again, without, I don't like to give people their conclusions, but as you can see, you're having a lot more mild to non-symptomatic cases through COVID, just through the increased number of tests. So as we stand today, since the beginning of COVID, these are some of the couple of the numbers you see in the media. For instance, we have over $6 million $6 million COVID cases. You don't see this number in the media, but we have recovered over 5.8 people have recovered or had no symptoms, and the total deaths 184,000. Again, balancing to that current people in critical care of 16,000. The recovery rate since inception is up to 97%, and the death rate, I've highlighted it, 3%. Reason I highlighted this, when I first started the data downloading back in the beginning of March, I was reading articles from the CDC on flu and the anticipation of COVID. At that time, the CDC had predicted that the COVID death rate would be around 3%. So coming out with 3.1 as we sit here on August 28th, with testing around 79 million Americans, the early prediction from the CDC appears to be somewhat accurate. You'll notice that we've now tested 24% of the U.S. population has received a COVID test. There'll be more on that number coming up rather shortly. So as I was publishing articles and also as information was coming out in the media about how the U.S. was faring as far as COVID goes compared to the rest of the world, I came out with the COVID Olympics, which we did last write-up. It was a competition between 18 nations looking to see who had the best response to COVID. We did some initial risk factors on each country just because we wanted to know who should we anticipate having good outcomes. We're looking at average age, urban population density, just items like that. I won't have a spoiler alert and tell you who won gold, silver, and bronze, but I'll just share some of the small samples that we used. And I wanted to focus on the testing part of it. So you'll see this, I have these nations segregated. Those top three, those are three of your top four as far as if you were to look for what countries have the most COVID cases. It's USA, Russia, Brazil. If you look at the USA and Russia, the percentage of the population tested is rather significant, 24%. And you can see the percentage of the population that is diagnosed with COVID, 1.83, US, pretty similar in Brazil, and Russia, 0.67. What I want to compare to is the nations that are getting a lot of good press about how well they've handled COVID. So if we look down to Japan and South Korea, you'll notice that the percentage of population that have COVID is rather small. They're both around 0.05%. But you'll also notice that the number of people that have been tested in those countries is also rather small. Japan has tested just over 1% of their population, and South Korea has tested just under 4% of the population. So this gets into the debate, should you be testing everybody? Should you be testing symptomatic individuals? So as you can see, are the Japan and South Korean rates lower just because they have had a better COVID response, or are they just lower because they've just not tested enough of the population to find out who has the COVID-19 virus in a non-symptomatic form. If you want the results of the Olympics, you'll have to reach out to somebody at Seubert. We'll share that information with you at another time or through the question and answer session. Again, you'll see USA has tested more people than the populations of many of these countries. So at 79 million tests, it's larger than the populations of the European countries and also of South Korea. All right, next topic. It's keeping it rather light here. As you know, there's two things that, as they say, are definite: death and taxes. I've chose to investigate the less punitive of the two, which is death. One of the articles that I published, I got a lot of feedback from, there's a lot of actuaries on the distribution, and they were questioning about are the deaths related to COVID, the 184,000 that we have currently, are those new deaths or are those just reclassified deaths that would have happened anyhow? We've investigated this about 3 weeks ago, but the timing, it's very timely based on what was published by the CDC and debated in the media since last Friday, stating that 6% of the COVID deaths, or 6% of the deaths as reported at COVID are just related to COVID. The rest of them were related to other morbidities and some of them, comorbidities. What I wanted to show is, here are just the statistics on the left. USA's population, we're over 331 million. Here's our reported cases. So the number of cases, number of people that actually been diagnosed with some form of COVID is 1.83%. I presented to a similar forum about 2 weeks ago, and I just raised the question, what do you think is the population of the US that has COVID? My low end answer was 5%. My high end answer was 20%. As you can see, the answer is 1.83%. And reported COVID deaths of 184,000. When we talk about death rates of 3%, that does not mean that 3% of the population has died from COVID. That means that 3% of the COVID people that have tested positive for COVID have died. Only 0.06% of the population has died as a result of COVID, 0.006. On the far right side, you'll see that U.S. annual death statistics, very, very predictable. Here's a run rate of the total deaths in the United States for each year since 2015. You'll notice that it increases right around about 1% a year. So when you get to 2020, we would anticipate the total deaths in the U.S. to be around 2.9 million. What the actuary set out for me to investigate is, will those 2.9 million become 3.1 million because COVID added an additional 200,000 deaths? The interesting part of this is about 8,000 people die every day in the United States, just as a course of what happens. You'll see that certain media articles will publish things like COVID on the LA Times published COVID decimates the South, 60% increase in deaths. When you read the article, it does not talk about Florida's daily deaths. It just gives you a percentage. What that means is, on an average, 30 people had passed away during each day, and that number was now at 48 people. So it is a 60% increase, but again, going from 30 to 48 deaths per day in a state that has 21 million, population of 21 million, I guess you can see if that is decimating or not decimating. We also found articles that came up on the New York Times that published the 18 states where the death rate has significantly increased. Number one was South Dakota. Daily deaths had increased 100%. What that means in South Dakota is they were averaging 1 death per day, and that had increased to 2 deaths per day. So that is a 100% increase. But again, when you look at articles that give you percentages but do not give you the actual numbers, just be mindful of that when you're reading.
There you go.
All right. Continuing the light topic of death, these are the top 4 causes of death the last 4 years in the United States. These top 4 have been the same every year. The order has not changed. So number 1, you can see heart disease, cancer, accidents, chronic respiratory disease. And these are others that have been in the top 10, stroke, diabetes, flu, pneumonia. They categorize those 2 events together, and suicide at 47,000. When you add chronic respiratory disease to flu and pneumonia, you get about 215,000 deaths. So the question will be, again, when we're able to analyze the 2020 data, are these COVID deaths that are being reported, these 200,000, 184,000 where we're at right now, will this be in addition to our regular U.S. death rate of around 2.9 million, or will we see the death rate triple up to the 3.1 million because of these increased deaths as a result of COVID? I notice every day there's states that are reclassifying deaths. This isn't some political blog ranting. These are actually CDC data. So on June 26th, New Jersey published that they had 1,883 deaths. When you dig into the information, New Jersey actually had 26 deaths that day. The other 1,850 were reclassified COVID deaths back to April 1st, where they re-examined the death certificates and classified them now as being COVID deaths. Same thing happened in Texas on July 29th, where 710 deaths were reported for that day. Texas typically had about 45 deaths. They went back to May 1st. And again, we're re-examining death certificates to see if they could, any of these could be classified as COVID deaths. So here's some current statistics and also looking at when COVID had peaked back in April, which we thought was when COVID peaked back in April. So prior to May 21st, the highest 7-day average of the confirmed cases was 33,000. That happened on April 11th. Highest 7-day average daily death count was 3,000. That happened on April 19th. You'll notice the lag between the 11th and 19th. CDC often says that when you see a surge in cases, it'll be 8 to 14 days where you'll see the death count also then increase. Deaths as a percentage of cases at that time was 9.2%, a rather high number. Since May 21st, this is up till August 29th, the highest 7-day daily average was up to 71,000. That occurred on July 19th. And the highest 7-day average daily death count, that was 1,218,000. That occurred on August 3rd. Again, you have this about 14-day lag. What you'll notice, though, is the deaths as a percentage of cases went down significantly to 1.7%. So when you look at the surge now compared to the when we were peaking in April, you have 38,000 more cases confirmed per day, but you're looking at 1,800 less deaths per day. So it sort of leads back to the information that we talked about earlier, where a lot of these confirmed cases are of the very mild or non-symptomatic nature. As of August 29th, this is the most recent data. We have, when I had to go to publish. So we're averaging about 43 cases per day, and the daily death count was just over 1,000, 1,067. That ratio was around 2.5, which was, again, lower than the historical death rate of 3%. Here's some statistics. These are your, I also see article that California, now has the most COVID cases. Coincidentally, California has the most people. Texas has the second most, highest population, Florida the third, New York the fourth. Again, when you rank COVID cases, they also follow 1, 2, 3, 4. Percentage of the population, very similar. Florida just slightly higher than the average. What's interesting is the percentage of the population that was tested. You can see New York really knocking it out of the park with 41% of their population tested. This is the state of New York. California, 28%. Also Florida and Texas, 21, 18%. And again, the U.S. average is 24%. So all these states, doing a pretty good job as far as the number of tests go. I put Pennsylvania on here just because that's Commonwealth that we live in. You can see what our percentage of the population, only 1% of Pennsylvanians are reported with COVID. But as you can see, the state of Pennsylvania not faring too well as far as testing goes. We are ranked number 49 out of 50 states when you look at the percentage of the population that has been tested. Number 50, if you're curious, is the state of Colorado. They're the only state that ranks lower than Pennsylvania as far as the population number of tests. Impact on healthcare. This will be our final slide. So if you were a self-insured customer, you noted that during April and May, you really saw a decrease in your claims. Why did this happen? Well, elective care and non-referred care were pretty much eliminated from the healthcare system. People still had premature babies, people still were diagnosed with cancer, people still had heart attacks, but all of that healthcare churn, that daily self-referred and elective, was removed from the system. We did an initial impact on what we thought this would look like based on carving up healthcare into 17 buckets, 17 potential costs. We anticipated this would be the average employer that had 150 employees. We thought that about $51,000 of that typical $1.5 million medical and RX spend would just be avoided. That would be totally removed, never to come back. We also anticipated about 25,000 of claims just being delayed. That were mostly elective items that were going to come back either in June, July, August, September. So when you look at 51 and 25, you add those two together, that's cumulative. So $76,000 in claims would have just been disappearing during April, May. We also anticipated about $12,000 in COVID claims, again, just on an average employer. We're not seeing numbers that high, as again, a majority of these claims are hitting the Medicare population, and they're hitting the the Medicare supplement policies. So the net impact of COVID on an employer, when you take the avoided claims of 51 less the COVID claims of 12, we were anticipating about almost a 3% reduction in healthcare spend. I I talked to two of the carriers in town, and I just wanted to know how are they going to handle these upcoming fully insured renewals because of this. You know, during the base period, you had this period of time where these claims weren't coming in. You know, knowing that these insurance companies are not benevolent people, I did not think they would just sit back and not let your base claims reflect it. So what I heard was going to be coming was this would be just a sample of your fully insured renewal for 2021. So you'll see a base period of claims. So that $1,466,000, just for some simple math, we took the $1,505,000 and we backed out that $38,785. So that would have been the base period of claims. Adjustment for this is something that the insurance companies will be putting into your calculation. It'll be worded something like the adjustment for self-referred and elective surgeries postponed during COVID. And this will be their attempt to estimate what claims did you not have during your experience period that you would have had. And as you'll note, they're going to add in about 56,000. What you also note is when you compare your adjusted base period of claims of $1,522,000, it is higher than your annual medical spend that you typically have at $1,505,000. Again, insurance companies, we're not dealing with benevolent people here. And if they're going to estimate something, chances are they're going to estimate on a little bit on the high side. So just wanted to give you an idea on what you would anticipate from a fully insured basis. If you're self-insured, again, you had the benefit of these claims not coming in. If you're interested in what impact that'll have on your stop loss renewal, I work with most of the major stop loss carriers in the country. When I just interviewed and discussed COVID with two of the top four, one of them has not had a COVID claim yet in the entire country, and the other one has had 2 COVID claims, again, spread across their book of business across the total United States. So again, we're not anticipating any type of punitive rating as a result of COVID on the stop loss market, as again, a majority of these claims have all been hitting the Medicare and the Medicare crowd. So again, I really appreciate your time. Wanted to leave some time for question and answers today, so we'll turn this back over to the folks of Seubert. Thank you again.
Well, thanks everyone. We have about looking at 13 minutes here. If there are questions in regards to health and welfare compliance for Erin, statistics around what John had reviewed in regards to the his COVID Olympics, or how healthcare purchasing looks like, what that looks like in 2021. But in summary, from a compliance standpoint, we've been obviously very busy since March. There's a lot of unique scenarios that have come up, and our team has been responsive to them. We anticipate that would continue for the balance of this year, and then even on an ongoing basis. And at the same time, in partnership with John, back in March and April, we've been doing heavy modeling around what the finances of healthcare mean to your organization in regards to your specific statistics. And I know he went through a general example today, but we'd be happy to discuss that one-on-one with our account teams, or certainly open the conversation right now with any specific questions that any of you have online. So how you would do that is type your question in the message box on Zoom, just to get a couple easy ones out of the way. This is recorded. This will be distributed along with the slides. So we will be doing that as soon as possible. But other than that, we open up the message box to specific questions right now. And if there aren't anyone, or if there aren't any, we really appreciate your time. We know it's the Friday eve before a long Labor Day weekend. So again, we thank you, and we appreciate your partnership as clients. And if there's any specific questions that come up as a result of this webinar, we'd be happy to address them on a one-on-one basis, either with Erin or within within your client team. Quick check, anything come in, Jen?
You're good.
All right, thank you, everyone. Enjoy your Labor Day weekend and stay safe. Thanks.